Good afternoon. Okay. My name is Grace Loud. Thank you all for being here today. This is the Community Engagement Core of the CBMHR October seminar. We pulled together a seminar slash outreach with the hope of raising awareness about breast cancer, prevention, screening, and also to highlight the survivors, the people who have been through it, as well as those who've walked the journey with others who've been through it. So we hope that you enjoy what we're able to pull together. We hope that you're able to engage with the panelists, get something out of the educational seminar, and also join us for the commemorative walk that we're going to have along the Tiger Walk. So today, one of the key things we'll be doing is highlighting our new breast cancer endowment fundraiser, a program that Dr. Ajawole spearheaded on our behalf. And so our hope is that this is something that will continue to push us forward in research and advocacy in this area. And Dr. Ajawole is going to talk a little bit more about that. And as I said, the educational seminar with Dr. Polly Niravath, and then the walk. Okay, keep moving. All right.
Texas Southern University's Center for Biomedical and Minority Health Research Community Engagement Core is funded by the National Institute of Minority Health and Health Disparity Research Center for Minority Institutions program. The CEC works directly with communities to identify and address health-related concerns and reduce health disparities related to ethnic minorities. We provide health education and partnerships with healthcare systems, federally qualified health centers, community and faith-based organizations. For more information, visit us on social media at CEC Texas Southern U or give us a call at 713-313-1233 or send us an email at cbmhrcommunity@tsu.edu.
So first, we have our wonderful debate team members. And so I'd just like to introduce them for a moment. Mr. Brian White is a junior theater major from Compton, California, and president of the debate team. Michaela is a sophomore political science major from Tulsa, Oklahoma. She's in the Freeman Honors College and president of Sigma Phi Alpha Forensic and Dialectical Symposium. And then Ileana, am I saying that correct? Miss Ileana Hall is a junior radio, television, and film major from Milwaukee, Wisconsin. She's also in the Freeman Honors College, and she is treasurer of the debate team and treasurer of Sigma Phi Alpha. Today, they're going to give us a presentation about We Roar Against Breast Cancer.
Hear the roar of the tiger. The Texas Southern University debate team is proud to present this Sweetest Theater presentation, scripted and directed especially for this occasion by head coach Dr. Gloria Batiste Roberts, based on the writings of assistant coach Dr. Andrea J. Shelton and late theologian Dr. Howard Thurman, entitled Hear the Roar of the Tiger.
Tigers roar a warning. Cancer is the second leading cause of death in the U.S. after heart disease.
Hear the roar of statisticians. Breast cancer is the second leading cause of cancer deaths among African Americans.
Men make up about 1% of breast cancer cases. The survival rate for male breast cancer cases is similar to that of female patients.
Older African American men are at increased risk, so self-breast exams are just as important for men as for women, especially if there's a history of breast cancer in one or more female family members. Hear the roar of healthcare providers.
African Americans are less likely to be diagnosed with advanced stage disease, difficult to treat and costly.
Hear the roar of family and friends.
African Americans are less likely to receive recommended treatment or may experience delays in treatment.
Hear the roar of survivors.
African Americans experience premature death as a result of cancer and have a shorter life expectancy as a cancer diagnosis after a cancer diagnosis compared to other groups.
Hear the roar of public health care workers. African Americans suffer higher rates of cancer due to obesity and other health-related problems, and genetics too may contribute in some cases. Hear the roar of community leaders.
African Americans suffer higher rates of cancer due to variations in socioeconomic status and limited access to quality health care.
Hear the roar of scientists and researchers.
African Americans suffer higher rates of cancer due to limited choices in food deserts and insufficient spaces for healthy recreational activities.
Tigers roar a warning.
To protect against female
And male breast cancer.
Don't let cancer prey on you.
Hear the roars.
Heed the warnings.
Oh God, I need thee.
Oh God, I need thee.
Oh God, I need thee. I need thy sense of time. Always I have an underlying anxiety about things. Sometimes I am in a hurry to achieve my aims and completely without patience. It is hard for me to realize that some growth is slow, that all processes are not swift, and I cannot always discriminate between what takes time to develop and what can be rushed, because my sense of time is dulled. I measure things in terms of happenings. Oh, to understand the meaning of perspective, that I may do all things in a profound sense of leisure of time. I need thy sense of order.
The confusion of the details of living is sometimes overwhelming. The little things keep getting in my way, providing ready-made excuses for failure to do and be what I know I ought to do and be. Much time is spent on things that are not very important, while significant things are put into an insignificant place in my scheme of order. I must unscramble my affairs so that I may live my life in order. Oh God, I need thy sense of order.
I need thy sense of the future. Teach me to know that life is ever on the side of the future. Keep alive in me the forward look, the high hope, the onward surge. Let me not be frozen either by the past or the present. Grant me, O patient Father, thy sense of the future, without which all life would sicken and die.
Oh God, I need thee. Hear the roar of statisticians.
Hear the roar of healthcare providers.
Hear the roar of family and friends.
Hear the roar of survivors.
Hear the roar of public healthcare workers.
Hear the roar of community leaders.
Hear the roar of scientists and researchers.
Hear the roar.
Hear the roar.
Hear the roar. Hear the roar of the tiger.
Thank you all so very much. And I understand there was a comment discussion. Yes.
Hello, everyone. My name is Michaela Wallace, as was introduced so gracefully. So I was asked to share a personal story with cancer at this panel. So my aunt Marilyn recently passed from cancer within the last week. She had pelvic cancer. She was battling with it for about a year. And she passed because she wasn't diagnosed until it had already reached stage 4. By that time, it had already spread to her bladder, and she didn't go to the doctor to get a diagnosis, and they weren't aware of it. So she started off with chemotherapy, but it wasn't enough to stop the spread. And because she was a smoker, it spread exponentially. So there wasn't much she could do. And about a week ago, she was put on hospice care, and she passed, and her funeral was on Friday. But I was asked to share because cancer affects more than just those who have it. It affects the family members as well. And seeing as I'm a college student, I wasn't able to attend her funeral. And as she said, I'm from Tulsa, Oklahoma, so it was kind of sad, you know, to lose my aunt and not be able to go to her funeral. So cancer is something that affects everyone very harshly, and I can only pray that, congratulate the survivors for one, and pray for those who have it themselves. So, thank you.
Wow, that was beautiful, right? Right. Thank you for sharing. I know we've all been touched in some way. I know that we're also streaming live, so we may have questions periodically, but if you have questions throughout, please just feel free to jump in. All right, and so now we're going to move into our panel, our lived experience and advocacy panel. And so Dr. Dominique Gwynn is our moderator, but she was needed elsewhere. So I'll be filling in for Dr. Gwynn. Today, we have 4 wonderful panelists with us who are going to share their stories and their journey. First, we have Dr. Tracy Kirkland. Is Dr. Kirkland where you? Okay. And so thank you, Dr. Kirkland, for being here. So I want to say Dr. Kirkland is from Petersburg, Virginia. She earned her undergraduate degree in nursing from Hampton, completed a master's in nursing at Virginia Commonwealth University, and earned a postmaster's adult nurse practitioner certificate and pediatric nurse practitioner certification from Johns Hopkins University in Baltimore. She's also completed a doctorate of nursing practice at Texas Christian University. So thank you so much for being here today, Dr. Kirkland. Okay, next we have Miss Cynthia Johnson. Hi, Miss Johnson, how you doing? So Miss Cynthia was diagnosed with stage 2 invasive ductal carcinoma in 2018, 1 year before she was old enough to begin regular screening mammograms. Since that time, Cynthia's 2 older sisters have also been diagnosed with breast cancer. And Cynthia is a breast cancer advocate and ambassador with For the Breast of Us and a Know Your Lemon certified global educator. Thank you, Ms. Johnson, for being here. All right, and so Ms. Diane Eigelhart. Ms. Diane, how you doing? Ms. Diane is a native of Austin. She attended the University of Houston as an undergraduate student. And upon graduation, she began her career in Houston ISD. She's been a survivor of breast cancer for 13 years. Her resiliency to survive breast cancer is journey of faith, building meaningful relationships with medical professionals, other survivors, and strong support groups. And most of all, staying prayerful and hopeful. And then we have Miss Mia Williams. Miss Mia Williams, thank you for joining us today. And so I apologize, I don't have your bio. Okay, but I would like to ask all of the members to please come on up and join us at the table.
Hi, my name is Mia Williams, and I am a 15.
Texas Southern University's
It's okay. I'm a 15-year triple negative breast cancer survivor. I'm also a 1995 graduate of Texas Southern University. So when I was asked to be here, I was like, absolutely, because TSU is celebrating 95 years of excellence. I graduated in 95. And so I had to represent my school in every way possible. I was a social service professional. I worked for Child Protective Services here in Houston for more than 20 years. I was a what they called us a disproportionality specialist, but I did racial equity work all across the state of Texas. And minority health is something that's very near and dear to my heart. And to see my alma mater actually take a bold stance to address the systemic inequities that impact us, particularly Black women, in every phase of our life, I find it very heartwarming. But I'm a mother of a 26-year-old, a 20-year-old who's a biomed student here at TSU, and a 17-year-old son. So I'm thankful for this opportunity. Mm-hmm.
Mm-hmm. So we hope that you kind of join in and interact with us, okay? So for our first question, please share with us the context in which you first became aware of a personal breast cancer diagnosis. And we're just talking about that initial moment And we can start with Miss Diane.
That initial moment when I received the phone call from my doctor was, I was at work, as a matter of fact. And she said I worked in HISD. It was right after dismissal. The buses had come and gone. I was in the school cafeteria and my cell phone rang and I answered it. And when you hear those words, your test came back positive. And your heart drops, everything just sort of drops, the world stops. And the first thing I asked myself was, you ask yourself, why me? What did I do wrong? Basically, I followed good health protocols. How did I get myself in this predicament? So you do have that moment of why me, but then you have to convert quickly and to your faith and what is going to give you that strength and that buoyancy to lift yourself up. So I was in that cafeteria room by myself. It was at dismissal, and I had to have a little private moment. You have that little sinking moment, but then I had to get up, stand up, and you dig deep for your faith, and you just start reading. I went to CVS right in my subdivision and bought a book for $5.99. I still have it. It's all about cancer, everything you want to know about cancer. And I read that book that night after the diagnosis from front to back and had to go to work the next day. But I just stayed up all night reading it and just began educating myself and building my support group with my family and said, we're going to follow the protocol, get a relationship with my doctor and move forward. So you do go through that awe moment and you just sort of drop and you have a stillness.
May I piggyback? Good afternoon or good evening. I'm Tracy Kirkland, and I'm an adult and pediatric nurse practitioner, approximately 26 years of experience, 35 as a registered nurse, having trained at Hampton University. I, on the other hand, am a provider that will call the patients and provide that information. And as a provider, we too receive training on how to deliver bad news. And one of the things that we do, we try to do face-to-face interaction when possible. We try to avail ourselves to be able to answer questions and to provide support. So my first patient that I diagnosed was my second year as a nurse practitioner. The patient came in for urinary tract symptoms. We created a rapport. I invited her to come back to have a health maintenance exam. She came back, and in her left outer quadrant, I palpated a solid mass. The mass had been there for years. She's had biopsies. She had seen people, but had not followed up consistently. Upon sending her for a diagnostic mammogram, she too learned that she had breast cancer. She had a 5-year-old at the time. I saw her through that procedure. She had her surgery. I coordinated care in terms of plastic surgery, but it does take, it's relational. So it's not just that patient receiving the news, but it's us as providers being trained on how to deliver the news as well.
Thank you for that. There was a formal training process for that.
We have simulations in our programs. I am an associate professor, and we do simulations where we practice providing bad news, and we receive feedback from individuals in order to be able to provide information in layman's terms as well.
Yes, Ms. Williams.
Yes, I'm gonna be honest. I was a funky mess. I was at court, and the doctor called my husband, and he knew the news before I did. And she wanted to make sure that I didn't arrive at the doctor's office by myself to receive the news. And so when he called me, he was like, "Hey, babe, I'm going to meet you at the doctor." I'm like, "For what?" "It's nothing. It's nothing." And I said, he was like, "No." And he was so insistent on him being there. And I just couldn't understand why. So I fussed the entire time. And then when we were in the room, and at the time I was 34 years old with 3 young children. And so, and there was no history of cancer in my family. So surely it's just a fibroid, right? That's because that's what we've been told over the years. Oh, girl, you young. And of course, I nursed, so I thought maybe it was a clogged milk duct, you know. And so, you know, you get on WebMD and you can just self-diagnose yourself. So I thought I knew what I was talking about. And I remember the words she said, at the end of the day, you're positive for cancer. So she said, I'm going to leave you two alone. And so I felt like I was in the middle of a Spike Lee movie. You know how everything is just spinning around you. And then we both just kind of sobbed. You know, we just kind of cried because we had 3 young children. And immediately we thought that cancer meant death. You know, there's no coming back from that. And ladies, I'm just going to be honest. I was like, I don't want nobody raising my children. So I got to fight this thing. I need to stay here and do this. And I was mad for a long time, but it was, I was not well, and I had to plan for my daughter's 3rd birthday party the next day. So it was a range of emotions that we experienced, but I count it all joy, and I would not take that journey for anything.
Thank you for that honesty. So Miss Cynthia, what about you?
I too was at work and I received the phone call. And the first thing that I could think about was, how was I going to tell my mother? That was a big one for me. How do I call my family, my grandmother, you know, and tell them that I have breast cancer? It kind of felt really surreal for a long time. And after my first appointment, and I came home with the folder and paperwork, and I saw it like written on paper, that's when it became real, and I kind of became emotional. And that was the first time I really cried about it. But I was blessed to have a really solid work family that surrounded me immediately. They knew when that call came in, we were waiting for the results. And so in those initial moments, I was okay, but everything quickly changes. And so it was kind of a little bit of a downhill spiral from there. But
I think that's what we benefit from is the honesty and what it was really like. Dr. Kirkland, I want to ask you something. So cancer screening, we know it's a critical prevention method. Considering this and listening to what you've heard from the ladies and then also with COVID, how has that just impacted screening in general?
Well, thank you. I would like to ask a question before I answer. How many of you know of someone that's been diagnosed with cancer during COVID? Any type of cancer? What about breast cancer? Okay. So what happened during COVID, we had shelter in place. So we had limited face-to-face contact. We had offices, medical facilities that were limited because many of their providers actually switched and assisted in acute settings and hospital settings because of the shortage. As a result of this, along with other factors, many individuals missed out on their normal screenings, on their healthcare screenings, whether it was for pap smears, whether it's your colonoscopies and your mammograms. So we've seen now a delay in early diagnosis in some women. We don't quite have the statistics, but what we do know and what I do know from personal stories that some women who missed out are now learning of their cancer diagnoses. And most recently, how many of you heard in the news about what? Katie Couric. That hits home. That's someone that we all know, and she too shared her story. She did not have her what? Annual mammogram during its designated time slot. She had it most recently, and she was informed of breast cancer. So what we're learning is that not only did the pandemic affect our communities in terms of morbidity and mortality, but now we're having to look at the potential incidence of delayed diagnoses as it relates to cancer. And if I can also share, as a pediatric nurse practitioner, we're also seeing what? A resurgence of childhood infections like chickenpox, measles, mumps, and rubella because of the delay in receiving vaccines. So we really don't know the long-term effects of what has happened what is happening and or will happen as a result of the pandemic.
So So one follow-up question I like to ask is, in general, what was your approach to routine testing? Like Ms. Williams, I heard you say that, it wasn't in your family. So was routine screening like something that you just automatically did?
Yes, I can honestly say I'm one that's well in tune with my body. So I discovered the lump while showering. I wasn't necessarily doing a self breast exam, but I was just showering and it's like, what is that? And so that's what prompted me because again, I was a young patient. And so it wasn't even time for my first mammogram was when I was diagnosed. So yeah, I would, no other, it wasn't even a thought. Fibroids ran in my family. So I just automatically assumed, trying to connect the dots, that that's what it was. But little did I know it was something else. Yeah.
I was diagnosed also right before I would have started routine mammograms, and I had both a maternal and paternal aunt diagnosed with breast cancer, but they got it kind of what they believed to be standard, late 60s, 70s. And when I told my doctors, they didn't think anything of it.
That's right.
And so I didn't have any early screenings. But again, I was diagnosed 2018, my eldest sister in 2019, and my sister closest in age to me had a double mastectomy last week. And we have no known genetic condition. But my sister, the one that was just diagnosed, because of the other history now, she was going every 6 months, alternating mammogram and ultrasound. And in that 6 months, she developed calcifications, biopsy, and due to being the third sister, she was recommended for a double mastectomy.
Diane, what about you?
Well, I did have a practice of routinely going to the doctor and being screened and so forth. Cancer does run in my family. Prior to being diagnosed, that was just a routine checkup. It really was, but I did not feel anything. When they did, I had a lumpectomy. When they did remove the cyst, it was malignant. It was the size of a peanut. So he was saying that might be why I didn't really feel anything. Everything felt normal. But fortunately, I have the habit of going to the doctor and taking, routine screenings.
Thank you for that. And so we have one question now for the audience. We've already made, so it's just true or false. First person raise their hand. So you can get breast cancer even if it doesn't run in your family. True or false? Okay. True or yes? So we got true. So who's gonna help me out? We got some prizes for you.
Oh, that's cute. That's cute.
Guess I should have said that first,
I
right?
should have said that first. They would have raised their hands up. That's
Oops.
cute.
All right, thank you. Okay, so now next, because we were talking about treatment, you raised treatment. So of the various treatment options available, what option did you select and what were your reasons for selecting that particular option? So Ms. Cynthia, I'm gonna start with you.
So I had a lumpectomy, chemotherapy, and radiation. That was what was presented to me. I wasn't really presented with any other options, and I did not know then what I know now. The sister after me, lumpectomy and radiation, and then the sister, even though stage 0, double mastectomy. And so with both subsequent sisters, we've been able to talk through a lot more, the different options, what's available, and to know to ask about second opinions and other treatments, which I didn't know at the time.
Dr. Kirkland, do you want to expound on that just a little bit about the options that are being presented to people?
Sometimes there are some inequities with regards to options. And again, I'm going to ask another question. How many of you heard of going flat? So that's an option. It means that you elect not to have plastic surgery to build up tissue, and you elect to simply go flat. In the literature, if you review, not many ethnic minorities are offered that as a treatment option. So one of the things that I do as a healthcare provider, family member, friend, confidant, because I wear a hat of all sizes on any given day, is I empower individuals to examine what the options are. to use expert opinions, to use the evidence to make an informed decision and to create your questions prior to seeing your provider and or your specialist so you can dialogue, you can interact with them intelligently versus being given information. You have your own agenda, you can own it, and you can provide questions. So going flat is an option. And I learned about that as a PhD student. I'm currently in my third year at Texas Women's University, and one of my colleagues or peers is conducting research. And as she's conducting her research and she posts on the discussion wall, I asked, well, what are your thoughts about ethnic minority? What does the literature or what does the evidence say about that? So I would like to share with you today that going flat is an option. So if there's ever anyone that you know of that may not be interested in having plastic surgery and having any other procedures done, share with them that that is an option.
Thank you for that. I appreciate that. And Ms. Diane, what about you?
Well, I had, after my surgeon, my doctor, I was diagnosed, I interviewed for I was recommended 2 oncologists. So I went to both of them to see which one I could relate to better. So between the 2 of them, I chose one with Texas Oncology, Dr. Frankie Holmes. She's since retired. And my treatment was what they call sort of aggressive. It was sort of aggressive. The term they used was the red devil.
Right.
I had to go through that. Yes, I had a lumpectomy. After the lumpectomy, I had the red devil, and that was in two forms. I did something for 6 weeks or something like that, took a break, then I had to come back for another 6 weeks. It was tough. And then I had the radiation. I was really blessed. I kept on working in HISD. My health held up with that. My body didn't deteriorate so that I could not go to work. And that was a blessing, that I was able to maintain my health through good nutrition. That little book I read from CVS, and then talking to the doctors and so forth about the proper foods to help you with battle breast cancer, the superfoods, as they say. And I was able to keep on working. And so that was a blessing. It was recommended, my doctor, because between the surgeon and the oncologist, I was really in good hands. My surgeon was so personable. And being in HISD, he had most of the people I encountered, my other colleagues in HISD that were going through breast cancer, we all had the same doctor. And so when we go to in-services and faculty and so forth, I had other people to talk to. His name was Kenneth Baker with Kelsey Sebo. Back then, everybody had Kelsey Sebo insurance with HISD, Aetna. And so many of us had the same doctor, and that formed a good relationship. Because I remember I went to one in-service at NRG, and this other colleague of mine, both of us had our treatment about the same time, and we walked out of the in-service together because I had to make my appointment. So I did have that good relationship, but that red devil was something. It took a lot of energy out of me, but fortunately my body had the stamina to take it. I did have 2 blood infusions. Your white cell counts go down, diminish, and so forth. And my daughter saw after me then. She took me to both of those because that's an all-day thing to have the blood transfusions. And fortunately, that lifted me back up so I could keep on going. And that was, really a blessing. I know some people don't have that experience, but I was able to bounce back and live through the treatment because it was rather aggressive.
Yes, I love Dr. Frankie Holmes. I went to her too. I chose that option. I had the option of either going to MD Anderson or to a smaller setting, and I chose to go to the smaller setting. And one thing that I'm so passionate about as a result of the treatment that I received was, had Dr. Holmes asked me one question. Well, if we could have expounded on one question, that's about clinical trials. I was 34 when I was diagnosed. So I was a young patient. So I would have been like prime tissue for someone to study. particularly on the type of cancer I have, triple negative breast cancer. That's the one that impacts African American women the most. And it's a very, very aggressive form of cancer. And so when she asked me, would you like to participate in clinical trials? I said no. And she said, okay. And we just went on. But if she would have asked me why, I think we could have had a really deep discussion, and potentially I would have probably, because I'm an out of the box thinker. And so one thing that I wish I would have known now is the more options presented to women that look like you and I to participate in clinical trials, simply because the medicines that we are being given are not for us, because they're not tested on us. And so how can they be effective if we're not a part of that pool? So, but I was given that same treatment with the Red Devil, and I was real dramatic. I stopped working. I probably could have worked, but I was just real big. I was listening to her, I'm like, oh my God, I was really dramatic. But I stayed off from work, and luckily I had the support system of my husband, and he had the support of his job. So he was able to stay on with me throughout my treatment. And that's something that a lot of women can't really say. And he's passed away now, but that was my support system. And he's the one that really helped me through, because there's another side of cancer that it affects you mentally. And I was really, I had a mental episode, I'm just gonna be honest, where my husband was this close to calling the hospital to come and pick me up because I wanted to stop treatment. I was young. What are you saying? I'm having to go through this. I'm bald. I don't have any eyelashes. I have this image that I'm trying to uphold, and I can't do it. It's just too hard. And that was a very dark side. You know, and luckily the prayers of the righteous availeth much. And I had some praying people around me where I was able to work through that, because there are different phases of cancer, and that's a part of it. So
thank you for sharing that. That was one of the questions we were going to ask about, because our center pushes the importance of clinical trial awareness and being aware. So I'm really glad that you mentioned that, because that's one of the things we're always focusing on. Did anyone else consider a clinical trial?
I was approached by Dr. Holmes when I went in to talk. She did talk to you before treatment started. She did try to build a relationship with you. And so she gave me a little folder with the treatments. The Red Devil was in there, and others and so forth. What would I opt for? And she did approach me with clinical trials. I just wasn't comfortable. A lot of that had to do with my knowledge base and what I had been exposed to previously. Now, I might think differently now. I'm older, been there, done that. But at that time, I wanted something tried and true. And that was tried and true. And they wanted to be aggressive. They wanted to stop it so that, put it in remission.
Before we entertain, I just want to interject as a researcher, and I conducted research on children with lead poisoning in Baltimore. There are a couple different things. So we have a decreased trust in terms of signing up to participate in clinical trials, and that's secondary to what? The Tuskegee Institute and other things, previous relationships. But that's the way we build science. We contribute to science. And as you stated, we do encourage more ethnic minority to participate, because as you're learning more about pharmacogenetics, it's not a one size fit all. And while these medications have been tried, or participants have participated in clinical trials, again, if they're not looking like us from a pharmacogenetic perspective, those medications may not work. And we're not just talking about clinical trials for cancer medications. We're talking about for diabetes, for hypertension, and for other things. So there's a growing there's emerging information that's coming out on pharmacogenetics. So I would encourage you, if you're offered the opportunity to participate, learn more. Don't back away, but be keen to learn more.
Yeah, that's worth an applause. And leaning
She
on your
had a question,
support
sorry.
system, if you
Mhm.
don't understand something, going to the people you trust to kind of support you to get the knowledge you need. Would you say that's a fair statement as well, Dr.?
That is, and also, and we do have a question from the audience. You mentioned mental health. In chronic disease, mental health is real. So whether, again, you have cancer diagnosis, you're newly diagnosed with hypertension and or diabetes, depression in individuals with chronic diseases and or new diseases is real. So as we're facing society, not just with the pandemic and depression, we have to acknowledge that signs and symptoms, being clinically aware to address signs and symptoms of depression is really important, not just for the mind, but physically, psychologically, and culturally as well.
Thank you so much. Okay, so now we've got a couple of questions for the audience. So you ladies have a card in front of you. So Miss Cynthia, we'll go with the card in front of you. Go ahead and call out your question.
Oh,
So the question is, do you still need mammograms after menopause?
Who wants to, yes or no? So, okay, and she's saying yes. Is that the right answer?
That is correct. The
All
answer is
right.
true.
All right, thank you. And can you read, is it a little bit on there about that?
So it says getting older is not a reason to skip regular breast health checks. In fact, your risk of developing breast cancer goes up as you get older. About 2 out of 3 invasive breast cancers are found in women age 55 and older. And as long as you're in good health, you should continue getting your mammograms.
Awesome. Okay, now Ms. Diane, would you like to read yours, please? The one in front of you?
oh, I didn't even know it was, I didn't even know it was there. Okay, I may need a little assistance with this. I'm a little visually impaired. What does it say there?
So surgery and needle biopsies can cause breast cancer.
Oh, surgery and needle biopsies can cause breast cancer to spread.
Is that true or false?
Is that true or false?
She said false. Okay, there we go. Now,
Mhm.
I've heard
Be
that a
able to read
lot.
it?
Have you all? Yes?
You want me to read it for you?
You don't have my glasses.
I'm helping out, Ms. Diane. So needle biopsies to diagnose breast cancer do not cause cancer cells to spread to other parts of the body, nor does exposure to air during breast cancer surgery cause the disease to spread. Sometimes a surgeon does find more cancer than the imaging scans or x-rays showed, but in those cases, the cancer was already there. It just hadn't showed up on tests that were done. So the answer is false.
Thank you.
Mm.
Okay, so Dr. Kirkland, my next question for you. So in light of all the treatment options that have been discussed thus far, could you tell us a little bit about mastitis versus did I say that correctly?
Mhm.
Mastitis versus inflammatory breast cancer and its implications for treatment.
So again, as an adult and pediatric nurse practitioners, I will have patients to present to me in their postpartum stage that are breastfeeding. And most recently, I won't say where, but I had a patient present like that. So when there is erythema or redness around the nipple, when the breast is tender, swollen, and engorged, oftentimes, as I'm teaching my students, I have to tell them, you have to think about other realm of possibilities, and we call that differential diagnoses. So inflammatory breast cancer could be one of those possible differential diagnoses, in addition to what? Contact dermatitis as well as abscess. So for mastitis, basically we warm compresses 2 to 3 times a day, appropriate antimicrobials or antibiotics to treat it. And if the symptoms continue and they're not improving on that regimen, you want to expand your differential diagnosis to consider whether or not it is inflammatory breast cancer or something else. So there are always options. When you're treating one thing, there's always the potential that other things could be lingering. So we look for zebras is what I tell my nurse practitioner students.
Okay, so
It's cute.
for everyone at the table, how would you describe, some of you've already described this, but the overall quality of care that you receive throughout this journey, provided to you, like through your treatment process? I know you some of you talked a little bit about that, like Ms. Diane, you seem to have had a lot of information and options, whereas Ms. Cynthia didn't seem that way for you. So what would you say is the overall quality of care, what that experience was like?
I have to honestly say, I was truly blessed. Like my experience probably wasn't like any other. I mean, from the point of when I told my gynecologist that I felt the lump, he walked my film down to the surgeon. He walked it downstairs to my surgeon. And she immediately started working with Black woman. And she was so kind and so informative. And I went into anaphylactic shock on the table, if anyone knows what that is. I had an allergic reaction to the dye. So I had a traumatic experience throughout the course of my diagnosis, but I had the most amazing care. I felt like I was handled with kid gloves, but that's not everyone's experience. But yeah, I have to say I had a great experience despite being put in a sorority that I didn't ask to be in.
I actually think that I had really great care. It wasn't until I got into the advocacy space that I began to understand and know about all the different treatments, resources. And so even not being presented a ton of options, I had a care team that I really appreciated, that I thought was always there for me, and they continue to be. But I do think that, the more you get into it, the more you learn. And so.
Ms. Diane?
Oh, yeah, I really did have it's a trying experience, of course, but I was pleased with my medical professionals. Dr. Trinith Baker was my surgeon, and he was just over the top. He really knew how to build those relationships. He was a very good surgeon as well. And anytime I went for my regular oncologist was surprised that he kept the routine tracking me along with her. So when I had my routine with Dr. Holmes, I also had it with my surgeon. He was keeping up with me, and that was a little unusual. And so I was very blessed and very grateful. And one of the things about it, Dr. Holmes had some other patients that needed a good surgeon, like I had. And she would, when I go, she said, "Well, Ms. Aguilar, how did you get Dr. Baker? How did you get him to do your surgery?" I said, "Well, I'm a part of the insurance system." And I said, "He seems to key into a lot of HISD personnel." I said, "I don't know if that has something to do with it, but I was just very fortunate," because she was trying to get some of her patients in as well, because he had such a good reputation. So that support system helped me with my support groups that I joined. I have Sisters Network up here. I did join quite a few support groups that gave me that lift. And of course, your journey with faith as well.
Absolutely.
So network just can't be underestimated, the importance.
No, networks cannot be underestimated.
And so for Dr. Kirkland, what are your thoughts about the quality of care that you're hearing versus what you actually see or prepare for in the field?
I think that there are great providers, and there are some providers who are not as in tune. I'm not going to say that they're not great providers. You have some that are a little bit more communicative than others. And I recommend, again, first of all, for each patient to do their due diligence. That means to research, to find out about your disease process, and to write down questions as mentioned previously. And when you're doing that and you have your appointment, you're able to engage intelligently. Okay. So with regards to the quality of care, there are some inequities, as we all know. My area of research is food insecurity, social support, and loneliness. And what we do, and what I have learned over the last 6 months, is that there are inequities, and these inequities are systemic. So they didn't occur overnight. But the more we can empower our patients, our communities to be knowledgeable about your bodies, about what's happening, about potential treatment options, I think that that will contribute toward the quality of care that's received. And it's also economics, right? What insurance do you have? And those who don't have insurance. So you bring in a lot of inequities with regards to those who are uninsured.
So what is one thing, if anything, that you wish you knew or thought about with regard to your treatment or the options selected? Now, looking hindsight.
No, I think again, I think I was pretty blessed. I had a great team around me, and I was given the right options. I didn't immediately have reconstructive surgery because I didn't want to have the muscle taken out of my, and that was so long ago. I didn't want to have it done. But last year, finally, I was able to have my reconstruction surgery. So that's cool. But no, I think I had a very well-informed team. And one thing I can say, if you know of someone who's been diagnosed, or if you yourself is diagnosed, always take someone with you. Because you won't be in the mind space to receive such a whirlwind and expansive amount of information. You need to have an extra eyes and ears to catch the things that you missed. So it's okay. I know we're all warriors and we want to be strong and we think we can do it on our own, but it's okay to ask for help. It's not a sign of weakness. It's actually a sign of strength. So be willing to take someone or be that someone for someone else.
And Miss Cynthia?
I would say more so not during my treatment, but I'd like to see more research, more candid conversations about what cancer treatment, hormone therapy does to your body and your life going forward. We don't talk enough about body slamming a woman into menopause and what that does, neuropathy and stuff after chemotherapy, and how you navigate living in a body that doesn't look or feel like your own anymore. And so that is an everyday struggle sometimes. And so I think, of course, saving lives is paramount, but that quality of life going forward needs to be studied and talked about a lot more.
Well, can I just piggyback on that? You are absolutely right. I'm so glad you said that, because dealing with the neuropathy, lymphedema, because of the side where you have radiation on that side, it impacts your heart. So who has a little pin-sized hole in their valve because of the radiation?
Right.
Me. Lymphedema. So those are those long-term impacts that we don't think about beyond the fluff of the pink.
Right.
Those actual survivorship ails that we have to deal with on a daily basis. So thank you for sharing that.
Well stated.
So social support and a movement towards better understanding the impact of women's bodies. And then Ms. Diane?
All that boils into self-advocacy. You have to be a self-advocate for yourself as you go through this. But I just want to say the residual I still have is tingling in my fingers, and I still walk a little funny. I still have that little tingling. So that's just something I'm going to have to live with and adapt with. But I brought this because I felt as though this says it all of about my journey. One of those support groups that I joined was Kelsey Sebo. I joined several, but Kelsey Sebo joined this one. And when we culminated it on Survivors Day, we all did some art therapy. And we made all a portrait, and they framed it for us. So anytime you walk into my home, this is the first thing you see. Because I'm just thankful and grateful that I'm still here. I'm able to walk and live with my parents, my children, my sibling, my granddaughter, one grandchild I have now. And I'm just thankful that I was able to be here. And hopefully I can continue to be here as long as it's God's will. So I know that there's always new diagnosis, but you have to always have the hope. You have to always have the hope and have the faith. And like you say, be a self-advocate and educate yourself. Read, okay? And listen to others, other people that have gone through what you are about to experience and so forth.
Thank you so much.
Thank you for sharing about the lymphedema. And I see some pharmacy students, I saw some earlier, but even with pharmacy students and nursing students, because of these potential complications like lymphedema, you have to teach the nursing students and those who are taking blood pressures, you have to what? Avoid taking blood pressure in that affected extremity. So
And the COVID
providers,
shot, too.
you have to know, and you have to know by asking questions. You have to avail yourself to ascertain important history, because that's the a criteria. You cannot, you have to avoid blood pressure. And she said vaccines and
Yeah,
that
when
affect
I just had my COVID, the third booster, and then the flu, I have to get it in the proper arm and everything. You have to be mindful of that.
Thank you, Ms. Diane. Thank you for sharing your
Yeah.
beautiful. I don't know if I should call it art. I'm calling, but thank you for sharing that.
That's
Thank
my
you all.
artwork, yeah.
Your artwork. Thank you all for sharing your story. I think this is a wonderful place to close. We have just a couple of more audience questions. So Ms. Mia, if you would go ahead and read yours real quick.
Yes. Right. If breast cancer runs in your family, you're sure to get it. True or false?
Okay, we got a false. We also had a false over here as well. What
And
is
the
it?
answer is false.
Does it give you any
Um,
information?
I'll just go to a truncated version. Know your family history empowers you to tackle the risk factors you can control. It should also motivate you to get screened regularly so that breast cancer is caught early. When it is small and hasn't spread, it is easier to treat. Talk to your doctor about your risk when you need to start screening and whether you need extra tests beyond mammograms.
And then Dr. Kirkland, you'll close us out. Last one.
Sure. There is nothing you can do to lower your breast cancer risk. This is a great one. False. While you can't change certain risk factors, and I tell patients you have things you can change and things you can't. You have your modifiable versus your non-modifiable risk factors, like getting old, we can't change that, the aging process. Having a family history, that's non-modifiable. You can do a lot to reduce your breast cancer risk. You can exercise, you can eat healthier, avoid alcohol, stay healthy, limit and or eliminate alcohol. But most importantly, be responsible. Be responsible about your health. That can go a long way.
And encourage breastfeeding.
Miss Dr. Lau, we didn't talk much about nutrition, but that was one of the things that I did change. My eating habits. I'm basically now a vegetarian. I've given up red meat. I only have to eat it if I'm in a situation and there's no other alternative and I'm starving, of course. But as far as my household, and if I have a choice in selecting what I'm going to eat, there's no red meat. And I can't tell you, I guess 13 years out, I guess that's the last time I had a hamburger. So everything now is plant-based and so forth. And many of the restaurants are leaning toward that, plant-based. And the superfoods were broccoli and spinach and carrots and the berries, blackberries, blueberries, and raspberries. So you come to my daughter always says, you come to mama's refrigerator, that's what you're gonna find on the shelf, all the berries and so forth. And that's just, those are some of my main staples.
Lastly, we would be remiss breastfeeding. There are new guidelines that came out this year. We like to encourage more ethnic minorities to breastfeed. It's healthy. It decreases your risk for obesity. It decreases your risk for certain types of cancer. And it's overall healthy. So we're trying to promote breastfeeding, especially in our ethnic minority population.
First of all, let me say thank you all so much. I'm gonna go ahead and bring us to a close so that way we can move to the next stage of the agenda. We just want to give you a small bag of our, just a token of our appreciation. Thank you for your time. You didn't have to be here.
Thank you very much.
Thank the audience as well for your engagement. So if there's nothing else, come join us over here and we'll get ready to move to the next step.
Okay.
I'm going to.
Thank you
Yeah, I'm
all
gonna go
again
to my
so very
sister's
much.
out there. You have a safe trip, Tracy.
All right. So we're ready to turn it over to Dr. O. Okay, you're welcome.
Thank you, everybody. Good afternoon and good evening. Thank you for staying engaged with us for the past hour. That was such an incredible panel session. Please help me to appreciate the panelists. Thank you for sharing your stories. Thank you for sharing, bringing us into your personal lives, right? Some of the things that you shared, you didn't have to, but we just want to say thank you. And please forgive me. There's something happening in my throat, but I'm going to speak as clearly as I can. So thank you again to everyone in the audience. Thank you for joining us. And I know that we have attendees on Zoom as well. Thank you for joining us on Zoom. Please, if you have any questions, go ahead and put those in the Q&A box, and we will be able to answer those questions. My name is Veronica Ajewole. I am an oncology pharmacist, and I also have the privilege of being the founding director of the Community Engagement Corps. Thank you so much. Thank you. So one of the things that we do in the Community Engagement Corps is to bring information to the members of the community. We are here to build trust. We are here to address health disparities and make conscious efforts in advancing health equity. In addition to that, we also recently received $1 million from CPRIT. So yes, it's $1 million. And I also have the privilege of being the program director and the PI on that grant. So if you look on the screen, this tells you all the great works that we do in Texas Southern University addressing health when it comes to breast cancer. So we have the Texas Southern Breast Cancer Screening and Prevention Center, and we are able to offer no-cost screening. So women that are uninsured or underinsured, they receive their screening at no cost. That's a big deal. So we are very grateful for that opportunity. We offer patient navigation. We're able to offer education and awareness, just as we are doing here today. And if you want to get more information about the great works that we do, the QR code is on the screen. It is also in your bag. Everyone should have received a bag. Sorry, let me just. So in your bag, you should have this pamphlet, and that pamphlet has the QR code that you can scan to learn more about our breast cancer program. So please share the information, share the news with people. At this point, I know we have representation from our elected offices. I'm going to bring them up shortly. But before we do that, please permit me to bring up stage my mentor. I have a soft spot, when it comes to me bringing up Dr. Olaleye. Dr. Olaleye has known me since I was a first-year student here at TSU. So I did forget to mention that. I'm a TSU alum. I graduated in 2015 in the College of Pharmacy. So I'm very happy to be back and to give back. But the moment I came in, I plugged into Dr. Olalaye's lab, and it's been great from there. So please join me in welcoming upstage Dr. Omonike Olaleye, the Senior Associate Vice President for Research and Innovation, and also a professor of pharmacology. Thank you, Dr. Ho. Thank you. Let's give it up for Dr. Ajewole. Thank you. Is it okay if I stand here? Thank you all so much. Thank you, Dr. Lawson. Thank you. Let's give it up for everyone who planned this event. The Community Engagement Corps of the Research Center for Minority Institutions. My name is Omonike Olaleye, and I have the great privilege of serving at Texas Southern University. This is my 15th academic year. So I feel so blessed that TSU is able to give back and impact our community. I bring greetings from Madam Lycia Crompton-Young, President Dr. Lycia Crompton-Young, as well as my own boss, Vice President Dr. Penn Marshall. Let's give it up for them because they let us do all these things and provide institutional support. I'm here to do one of the most important things we're here to do today that we've all been waiting for. It's very key to know that as a university, TSU is one of the largest historically Black colleges and university in the entire country. And we sit in the third largest county in the country, Harris County. We're also part of the fourth largest city in the entire country. So the type of research that we do, the type of community work that we do has great impact on not just on a local level, but on a national level. So that is very critical to our students, our faculty. And so when Dr. Ajewole received this huge $1 million grant from the state of Texas, it was really big for Texas Southern University. Let's give it up to her and her team for making this happen. It's a huge
team effort. In addition to that, we received a $8.6 million grant from the National Institute of Health to develop a community engagement core facility, but more importantly, to address minority health issues and health disparity. Dr. Ajewole, like she mentioned, is a founding director. I felt so bad calling upon her, Dr. Loud, and the entire team, Ms. Bean. They're all working really hard to impact and move the needle. This country is suffering from things that have happened for several generations. It's going to take a huge team. Enough of us talking, okay? It's time for action. Somebody say action. And that's why we're here today. We're gonna do our walk, but not only are we gonna walk, we're going to join in and put what I say, put our money where our mouth is, okay? And this is how I speak to the federal government, our local authorities, our legislators, that enough of us just having events. We need to actually move the needle. People are dying from things that are preventable, okay? And a lot of research has gone into breast cancer research. So we're very blessed to be here at this time. However, I think it was Dr. Kirkland that mentioned the fact about what we call pharmacogenetics and pharmacogenomics. So when those medicines come out, they're not made for our population. And it turns out that's part of my research area is in pharmacogenetics and pharmacogenomics. So I know the key that it's very crucial that when we do those drug discovery and drug development, that we're actually making drugs that's not one size fits all, but we're making medicines that can impact and that can be efficacious for our populations. More importantly, we want to make sure, like you heard them saying, we want to make sure that these drugs are not toxic. Okay, we're not trying to cure cancer and give you some other disease. So this is at the core of what we do here at Texas Southern University. We also recently received a state grant, actually not recently, but in 2018, to solve cancer issues. And one of the biggest things is that Texas Southern University here, we're like a really hidden gem in this largest Texas medical center to take anti-cancer drugs from the bench all the way to the clinic. So right here at CSU, we have a facility for preclinical drug development in the area of cancer to actually bring out potential anti-cancer medicines. But we want to make sure that we're not just helping the largest medical center, but these medicines are safe and very potent for our community. So CSU is so blessed at this point. And we want to also address the issue of underrepresentation in clinical trials. And I'm just so excited because it feels like everything, the line is falling to us in the right places. We have great leadership, we have great support, we have great institutional infrastructure, we've developed great relationships on the national level, local level. We have the great people, Dr. Ajewole and her team, and Dr. Lau, to solve these types of issues. So now is the time for fundraising. I want you to pull out. So in your bag, you should find this right here. And inside this, you would find a QR code. And I think they had it on the screen. This movement, I call it a movement. It's a call to action for breast cancer. It's addressing a lot of things. More importantly, like Dr. Ajewole said, bringing awareness and advocacy. We have to educate our community. We have no-cost screening. Let's give it up for them again. No-cost screening for breast cancer and diagnostics. More importantly, I don't know if Dr. Ajewole mentioned this, Texas Southern University has invested into a mobile health coach. Did you mention that, Dr. Ajewole? That would actually go into our communities, and this mobile coach is equipped with a mammogram. Let's give it up for TSU. More importantly, for Dr. Ajewole that came up with that brilliant idea, and our president that supported us to make this happen. So we'll be rolling that out in a couple of months. So I want you to really make not just an effort from your institution, but more so even a personal effort. I call it putting your money where your mouth is, okay? And I'm starting with myself. So both personally and also from my specific department, Division of Research and Innovation, we will be part of this fundraising for the breast cancer program because funding is limited. So not only do we have to deal with the generational impact of the inequities and injustice that has happened to our populations and having to deal with the disparities in our health outcomes, we also have to deal with this on a structural level when we apply to grants and for funding. Okay, we have grants where we've applied to and got really great scores that our colleagues at the medical center will apply to, and they will even get bad scores and get funded. And so I've had to fight these types of things on a national level. So while we're using one hand to fight it, to get more funding to support these types of efforts, we also have to personally put our money where our mouth is. We also have to put, as an institution, we're putting a lot of effort into this. We recently received a huge funding from AFLAC to support these types of efforts. So I really encourage us, those that are watching online, you have the Zoom code, the QR code on there. I hope they can show it to you, but also to be able to be part of this effort. And we have different levels of funding. We have for individual donors, you can do the $50 funding, you can do the $100, $250, and in the article, it has all the different levels of funding. You can have the 500 level and the 1,000 level. And all of this is very key for us to be able to bring no-cost screening diagnostics to our community. Also, we have corporate sponsorship. You can be the Pink Magnet sponsorship, which is going to be $1,000. And we have the $2,500, the $5,000, and $10,000 or more. We are a movement to really close the gaps in our communities, and working together, I believe we can make this happen. So thank you so much, and make sure you do not leave today without, it doesn't matter how much it is, but it's very key that you tie in, because we already have our infrastructure, we have our faculty that are doing excellent work, we have our students. Give it up for our students that I see all over the place doing excellent work in this area. So thank you so much, Dr. Ajewale and your team. I'm super proud of you. I am super proud of what you're doing for Texas Southern University. I just pray that you and Dr. Loud can duplicate yourselves, and we can have more faculty that are doing this type of great work. Thank you so much. Nice seeing you, and I can't wait for us to go walking. Thank you. Thank you so much.
Thank you so much, Dr. Olale, and thank you to everyone in the audience. Like Dr. Olale has said, please scan the QR code and feel free to, put the money where the mouth is, right? We want to address health inequities. We are here in TSU to do just that. I know if we look on our schedule, we are supposed to transition to the monologue, but I want to be very respectful of the time that our elected officials have, made time to spend some of their time with us this evening. So I would like to bring up the representation from different elected offices so that we can do the proclamation and give out the certificate of recognition. And just so we know what's coming up next, after this, we have a monologue. We're going to have a webinar presentation by Dr. Niravath. She's an oncologist from Methodist Hospital. And then at 7 o'clock, we will be ready to go out for a walk. So the day is not over yet. Don't leave. We just want to make time out now to bring up stage the representation from the elected offices. So we have representation from Congressman Al Green's office. Thank you so much. Thank you. Please join up stage. We have representation from Congresswoman Sheila Jackson Lee's office. Okay. Okay, she's coming for the walk. Thank you. And then we have representation from Representative Ron Reynolds' office. Thank you so much for joining us. I appreciate you, sir. We have representation from the City of Houston, Mayor Sylvester Turner's office. Thank you, Ms. Veronica, for coming. I appreciate you. We also have representation from Councilwoman Leticia Palmer at large. Plummer, thank you. I appreciate you. Thank you very much. Thank you. Okay, at this point, I guess.
Well, I'm going to be brief. Good evening. It's great to be here back at my alma mater. I'm a proud product of Texas Southern University, and I'm Ron Reynolds, State Representative and Chair of the Texas Legislative Black Caucus. I want to thank Azib and Dr. Tatum for inviting me this is so important. And it's so great to hear about that grant that you received. For those who don't know, unfortunately, Texas has the largest uninsured population in the country. And so there are so many health disparities when it comes to Black and brown communities. And unfortunately, Texas leads the nation in maternal mortality for Black women. And so we are so grateful to hear about this because so many people don't get mammograms. So many people don't get treatment because they lack insurance. And so we got to do something to change that. We're one of 12 states, but thankfully you all are leading, and that grant is going to help save lives. So I'm here today just to say thank you for all that you're doing to help those with breast cancer. This is important to remember, not just during October when we're proud to wear pink, but throughout the year, every day people die. And there's so many disparities that exist. So let's continue to do what we can to sow seeds, to give donations, to show support, not just prayers, but we need to lead by example with our donations, to keep the awareness, to keep the research, to keep the support going, and to make sure that we're supporting those women that don't have access to healthcare. So I'm proud as state representative to present a certificate of recognition from the state of Texas. And this is for you doing this. I'm giving you a community service award because this is truly great service to our community. So thank you for everything that you're doing, everything that you're going to continue to do, and for all of those students that are studying. What a noble profession that you're entering. Thank you, and God bless you.
My name is Colby Beavers. I'm here on behalf of Congressman Al Green's office. Just to reiterate what State Representative Reynolds said, this is a great program. It's much needed for the community. As a Black woman, I know the risk, I know the issues, but there are a lot of people exactly like me, Black and brown, that don't. And so this is a great opportunity for you to come out and learn and know so much, especially the people online. I hope you guys are chiming in and getting as much information as possible because it's amazing.
And I'm with the Mayor's Assistance Office and representing the City of Houston. And I see as a representative in the Southwest area where we have communities in the Gulfton community who were in need of going to do their breast screening and need more information, engagement, outreach out there in the Southwest area with a lot of communities that still don't know where to go and how to obtain services. And we brought a proclamation on behalf of the mayor.
Greetings, I am CeC Scott. I'm from the office of Councilmember Dr. Letitia Plummer. So proud to be here and so proud to say go Tigers, happy homecoming, as I am a TSU alum. I'm here today on behalf of Councilmember Plummer to help move this needle. This certificate of appreciation is for We Roar Against Breast Cancer, Texas Southern University. On October 25th, today, Texas Southern University is hosting its inaugural We Roar Against Breast Cancer Center. It's an interactive educational seminar. The panel discussion was outstanding. Thank you for having us. Thank you for putting together such an outstanding panel. The questions and answers, the information that they shared, outstanding. And so on behalf of Councilmember Plummer, we look forward to the Walk Against Cancer taking place today on this, the 95th Homecoming Week. The purpose of this event is to educate and raise cancer awareness for breast cancer. TSU provides services through quality information, increased health education, and clinical research access and community resources to promote health, equity, and improve overall quality of life. Therefore, I am honored on behalf of Councilmember Plummer to recognize Texas Southern for their arduous work, big TSU work, in the city of Houston in advocating for breast cancer awareness, research, and prevention. Thank you so much for your time. Go Tigers and go CBMHR, Texas Southern University Screening and Breast Cancer Prevention Center. Thank you. Oh, declare the day. Declare the day on behalf of the mayor.
It's a long proclamation. So on behalf of Mayor Turner, therefore I, Sylvester Turner, Mayor of the City of Houston, hereby proclaim October 25th, 2022 as Texas Southern University, we roar against Breast Cancer Day in Houston, Texas.
And I just want to share how significant this is. For those who don't know, you have representation from the local, the municipal level where you're closest to the government with the city, the state, and the federal government. So you're represented on all levels of government. And this is the kind of cooperation we need to help to combat the systemic issues that are associated with breast cancer. And thank you. Thank you.
Well, we are very honored to have received, this recognition from all levels of, political representation and our elected officials. If anybody asks me, why does this matter? This matters because we cannot address these disparities single standing. We need money, we need advocacy, we need policies and decisions to be made that would empower and enable all the things that have been discussed. Survivorship is a big deal. Screening is a big deal. Access to timely treatment and the right treatment is a big deal. And that is what we are here representing this evening. So thank you to all our elected officials for making time to join us in today's incredible presentation. This is not just a moment, it is a movement, because we are not just going to stop today. This is the beginning of great things to come. Thank you very much. Thank you very much. One more. Beautiful. Thank you. Thank you very much. We are very honored. Thank you. Okay. Thank you. Thank you all. Thank you, Dr. Lale. Thank you to the entire volunteer team that is making this a success. Thank you all. Thank you to the CEC group and to Ziomara, our program manager. Thank you, everyone. Again, the program is still continuing. We are not finished yet. I would bring up stage now the Baylor College of Medicine to come and talk briefly regarding the monologue, Beauty from Inside Out. Thank you for joining us.
Thank you guys so much for inviting us here to this event. My name is Millicent Lacey. I'm with Baylor College of Medicine and the Dan L. Duncan Comprehensive Cancer Center, joined by my colleagues, Hector Sanchez and Ricky Valdez. We're here today to present Beauty from the Inside Out. So within the Dan L. Duncan Comprehensive Cancer Center, we have a community outreach and engagement department. Within that department, we have a theater outreach program. So many of you may be thinking, theater, cancer, how are these two correlated? Well, what we do is we work with local playwrights to develop culturally and linguistically appropriate full-length plays and monologues. And we show these plays and monologues for minorities, communities within Houston and surrounding areas. And what the goal of these monologues is to raise awareness about cancer screening and early detection for some of the most common cancers, colorectal, cervical, and breast cancer, which is why we're here today, as well as HPV vaccination and clinical trials participation. So when we show our monologues, we ask that you complete an evaluation survey. So later on in our program, we're going to be passing out a survey. And that's just going to get some feedback on how you enjoyed the monologue and also help us to provide a better experience when we do these presentations. So we want to hear your feedback about how you received it, if you have any suggestions. And by completing the survey, you were entered into a chance to win a Visa E gift card, a $50 Visa E gift card. So the raffle is completely optional, and we do ask for your name and contact information, but for your awareness, that's only for us to contact you if you win. We're not using your information to contact you about anything else. So we would appreciate if you would fill out that survey. And so also this information, if you want to take a screenshot, we partner with Harris Health because they provide information on preventative care. And also for if you need help assisting with money or lack of insurance, Harris Health is the go-to to help aid you in preventative care for your breast cancer screenings, mammograms, and things like that. So always feel free to reach out to them for assistance. And also, so like I said, we provide a monologue for breast cancer awareness. We also have monologues that deal with colorectal health and also HPV vaccination. And we also do monologues on clinical trials. So if you're interested in those for your communities and your churches and things like that, we can come out and present those monologues. Hector's information is up there for you to reach out to him, as well as my information is millicent.lacy@bcm.edu. Not sure where the monologue, okay. So just for some context, the monologue we're presenting is called Beauty from the Inside Out. And what it's doing, it's a play on, if you guys are familiar with YouTube makeup tutorials, and this is what the actress in this monologue is doing. She's giving a YouTube makeup tutorial on a smoky eye, but also sharing some breast cancer awareness facts throughout her tutorial. So we are excited to present this. It's about 12 minutes long for your awareness.
Hiya, it's Maya. Welcome to Healthy Beauty with Maya. And today we're going to do show and tell. That's right, show and tell. Oh, hey, Dana, glad to see you back. Hey, Roxy. So as I was saying, I'm going to show you how to do a smoky eye. Now, I know I've been promising y'all for a minute we were going to do this smoky eye. It's not as complicated as it may seem, I promise. Hi, Miss Mildred. Hey, David and Michael. Okay, so as I was saying, while I show you this eye, I'm going to tell you something too. You know how I always say, a beautiful outside starts on the inside. Oh, hey, Susanna. Okay, I'm just getting everything set up here. I will show y'all everything as we go along. So anyway, I was over at my mama's to do a little cleaning. She's trying to help me any way she can with a little change since I'm holding down my hospital job, putting in days at the nursing home, plus the gym, and the fun part, y'all. Okay, so I'm assuming you have on your base a hint you want some, don't cake it on, moderation. Anyway, I'm dusting at my mama's house. There really isn't any dust at my mama's house. So I'm dusting the coffee table, and sitting on top of her old magazine next to her daily word is this booklet about breast cancer awareness for young African-American women. Now, I've told y'all before, Mama D is not known for her subtlety, so I know this is something I'm supposed to read. Okay, so we're gonna apply our neutral base shadow. I'm using Bella Cafe by Milani, but you may use something you like better. That's fine, just get it all over the entire lid. So, back to this booklet. At first, I just flipped through the pages, hoping I could skim it and be done. But something on page 4 really caught my eye and made me go all the way back to the beginning to really read it. A study from 2019 reported that close to 34,000 African American women were diagnosed with breast cancer that year, and more than 6,500 of us died from it that same year. Wow, 34,000, that's like around 50 jumbo jets being diagnosed, and the equivalent of more than 2 9/11s being lost. Whew, that's really rough. Oh no, Yolanda, don't go getting all scared, and that goes for the rest of you too. But one other thing, we African American women are dying at a higher rate than our white counterparts. It could be that we just aren't getting screened soon enough. So if you honestly believe something isn't right, then get on it. Going to the doctor when we first notice something is different can help the doctor decide if we need a mammogram. You know, the test that can help us get a better look at what's going on with our breasts. Now, usually we don't think about getting a mammogram before age 40, and then it's something you and your healthcare provider can decide together. Ooh, y'all's faces. Quit it. I'm not trying to scare you, but it is important. It's information, that's all. Okay, so we're gonna take our smaller brush, and now we're gonna put some of that pretty plum in the crease and a little higher. Yes, plum. Oh, plum, deep plum. That's shaping up just fine, yes. Trust me. And trust me on this breast health info too. I would not be taking y'all's time with it if it wasn't important. Now, that 2019 study also found that a high number of us Black women who are diagnosed with breast cancer are under 45. And we Black women in our 30s are dying at double the rate of young white women in the same age bracket. What? Brianna. Yes, this is a beauty vlog, but health is the first foundation to beauty. Right, y'all? Sister, I know you're not getting snippy with me. Now, grab another shadow brush, same size. We're going to go in the middle of the lid now. So, booklets. I'm just going to share with you some of the risk factors that are most pertinent to our age group, which is about 25 to 39. Numero uno, family history. We really need to know more about the health matters of our elder relatives. A great-grandmother may have had breast or ovarian cancer, and it's never been mentioned. Again, don't be getting scared. That's not what this is about. But heredity is another factor when it comes to awareness for us. So ask. And one thing we really need to ask about is a gene mutation called BRCA, and if our relatives have had genetic testing to see if this runs in the family. If this factor is present in your history, you need to be aware of a very aggressive breast cancer called triple negative that attacks younger women, particularly us Black women. Oh, Yolanda. Sister, I'ma message you. This is just important, that's all. Okay, I'm getting back to makeup. All right, you beauties, let's get the same size brush. We need to get some dark gray down on the lower lid. That's right. Hey, too bad it is at night. You could just step out the door and party. Speaking of party, some of us really get to enjoying our cocktails. Okay. This is not a lecture, but overuse of alcohol is another risk factor for breast cancer. This is not hearsay. This comes from real research. So come on. We know how to use moderation and still enjoy ourselves. And come on, y'all. We cannot be smoking. And don't act brand new about vaping either. Vaping equals nicotine intake, which equals the same problems as tobacco. So put down the smokes and the vape pen. And if you've never started, don't. Okay, let's line. Who said finally? I'm using a powder. You may use a pencil or a gel if you like. I like to go from the outside in. And we're going to do the bottom two. Now take your anchor brush in your light gray and swoop a little bit of color under the bottom lash. Ooh, looking good. Okay. Now take a minute, check everything over and make sure it all looks right so far. Take your time and look carefully. Another thing you really must check is the way your breasts look. Get a really good look so you know what is normal for you. One may be a bit larger, and if they've always been that way, then again, that's normal for you. If there is a change in size of only one breast, that signals a need to at least ask doctor to take a look. Also, if the skin on the breast gets dimpled like an orange peel, please get examined. None of us is 40 yet, and that's the usual age to start having mammograms every year. But if something seems not right, you and doctor may decide to have one done. And for heaven's sake, please don't worry. You may not even need help, but if you do, you found out early and can get all the benefits of early detection. Now, this is nothing to be afraid of. It's just something to be aware of. All right, the finisher. We're gonna pop on the lash. Now, for heaven's sake, y'all, please trim your lashes. Wow, whose stomach is that rumbling? Ah, wait, it's mine. When I'm done with this, I'm gonna go grab the rest of my salad. It was really huge, so I have about half of it left. I have to go take a class, then teach a class at the gym. Did I tell y'all? I'm an LVN now. I'm in my second semester of classes to be an RN, and I'm teaching Zumba at the gym. So that's my exercise right there. The booklet also stated we have to do some kind of exercise and that we can't become very overweight. Now, I haven't said one word about thick, have I? No, so don't anybody get mad. The booklet said being extremely overweight is a risk factor. Nobody said we had to be a toothpick. Let's just eat healthy and exercise, and that should do it. Now put that lash on. If you don't wear lashes, then be careful to put mascara on in layers, which will give you the thick lashes you want. Okay, we're done. We have our beautiful, dramatic, smoky eye. Terrific job, everybody. Okay, let's do a little review. For the smoky eye, we have our base, neutral, plum, liner, and lash. For breast cancer awareness, know your family history. They know. Make them tell. Get familiar with your breasts. Notice any changes. Keep physically active. Keep your alcohol consumption low. Watch your weight and keep those cigarettes and that vape pen out of your life. And if anything seems not quite right, get in and see your health professional. A mammogram can find a tumor the size of a grain of sand before it grows any bigger. You all got it. I'm sure you did. And so until we meet again, my beauties, remember, beauty begins with good health. Contouring next time. Bye from Maya.
That was awesome. Thank you so much. Okay.
To close us out, just also for your awareness, monologues used to be live performances by actors and actors before the pandemic. So we're actively getting back to being able to have live performances. And so right now, my colleague Vicky is passing around the survey that we mentioned. And so it looks like this. It's going to be front and back for you all to fill out. And again, please leave your information if you're interested in being contacted to win the raffle. And we so appreciate, again, you having us here today. Breast cancer awareness and breast cancer is near and dear to my heart. I have a sister who's a breast cancer survivor, as well as a stepmother. So thank you for your time today.
I think at this point now, we are approaching our webinar session, and we are very excited to have Dr. Niravath in the house. I'm going to bring her up stage, but before I do, I want
Texas Southern University's
couple of
Center for
announcements
Biomedical and
about our
Minority
center.
Health Research Community Engagement Corps is funded by the National Institute of Minority Health and Health Disparity Research Center for Minority Institutions program. The CEC works directly with communities to identify and address health-related concerns and reduce health disparities related to ethnic minorities. We provide health education and partnerships with healthcare systems, federally qualified health centers, community and faith-based organizations. For more information, visit us on social media at CEC Texas Southern U or give us a call at 713-313-1233 or send us an email at cbmhrcommunity@tsu.edu.
Awesome. So that's really about us in the Community Engagement Corps. Remember to stay engaged. Again, I want to say thank you for all the attendees that are physically here in the building and for those that are joining us online. Remember that we're going to have a walk on Tiger Walk right after the webinar session. And we also have food. So we have boxed dinner that everyone can pick up at the end of today's session. If you have any questions for those online, please post those questions in the Q&A box and we'll be able to take them at the end of today's presentation. Okay, we want to say thank you to all our sponsors, right? We have, several organizations that are sponsoring food, bringing snack, bringing water, to support the great works that we do. So we say thank you, as well as to all our vendors. We have vendors in the building, as well as all the way on the Tiger Walk Trail. So please stop by at all the vendor tables to, thank them and pick up helpful information about the different services they provide. Yeah, another page again for vendors. And now I would bring up Dr. Niravath. Before I bring her up, there's going to be a survey because, we are grant funded, right? With grant funded programs, we rely heavily on feedback based on, what you tell us the survey. So the survey link is on your page. There is a QR code right there that says survey. So please scan that QR code and complete the survey. We also have paper survey available if you want to complete that. For those that are joining us online, we will post the survey link in the chat box so that you can also complete the survey. All right, so Dr. Pauline Niravath is a board-certified physician by the American Board of Internal Medicine in Oncology and Hematology. She is a breast oncologist and the director of the Cancer Survivorship Clinic at Houston Methodist Cancer Center. Our goal is to offer comprehensive care to patients from diagnosis to treatment and to long-term survivorship care. Our primary interests are in breast cancer, symptom management, aromatase inhibitor side effects. Dr. Niravath's research focuses on minimizing treatment-related side effects for breast cancer patients. After completing her medical training at the University of California, Dr. Niravath completed both her residency and fellowship at the Baylor College of Medicine here in Houston. There she received an Excellence in Teaching Award, and she has also earned grant funding for clinical research from sources such as NIH and NCCN. Dr. Niravath is a member of the American Society of Clinical Oncology and American Association of Cancer Research. She sees patients at Houston Methodist in the medical center, and she is also fluent in Spanish. In addition to what I have on the board, Dr. Niravath is also the co-PI on the 1 million CPRIT funded grant. So thank you so much, Dr. Niravath, for supporting our effort, for believing in us, and for joining us in person into this program. So please join me in bringing up stage Dr. Niravath. Thank you.
Can y'all hear me okay? Okay, great. Thank you everyone so much. I'm really excited to be here and talking about breast cancer. As you all have probably gathered, breast cancer is one of my huge passions in life. It's what I wake up every single day trying to improve our general knowledge of breast cancer, trying to help women who are battling breast cancer every day. So I hope that during this talk, it will be helpful and informative, and I hope that it can be a little bit interactive too. So if y'all have questions about anything, please feel free to raise your hand and let me know, and we can take any questions during or after as well. Okay, so first I'm going to talk a little bit about breast cancer risk factors. So there are many risk factors for breast cancer. The biggest one far and away is age. So we know that as ladies get older, their risk of breast cancer definitely increases. Race is also a risk factor. And I'll show you here, this is a graph that combines both of them, both race and age. And you can see here that in general, as we get older, which is this axis here, risk of breast cancer goes up, and it really starts to peak here, which is around people like in their early 70s or late 60s. And you can see that it's different by race also. While white women have the highest risk of breast cancer, you can see that's these red circles here. You can see that African-American women are also significantly affected by breast cancer, although less so than white women. The African-American women are depicted here with this kind of purple square. The interesting thing, and this was discussed in this talk before as well, is that African-American women actually have a higher risk of dying from breast cancer, although they have it at lower incidence. And a big part of this reason, we believe, is because the biology of breast cancer in African-American women is actually different, meaning that African-American women are more likely to have triple negative breast cancer, which is an aggressive type of breast cancer. And also many times African-American women may not have the same access to healthcare. They're more likely to be uninsured, may not have access to a screening mammogram, may not know the importance of it. So this is why we want to get the word out that this is important for every woman, but especially for African-American women who actually have more risk from this disease than many other Americans. So other risk factors that we look at are the personal history of the person, of course, which is really important. If somebody's had an abnormal mammogram and has had a biopsy that shows a high risk finding, then these people are at higher risk as well. And sometimes we even start them on medications to help reduce their risk of breast cancer. Also, family history is very important. If you've had especially first degree relatives with breast cancer, so meaning a mother, a sister, a daughter, these are all things that significantly increase your breast cancer risk, but also further relatives as well. So grandmothers, aunts, cousins, and so forth. Another thing that can increase the risk is radiation therapy to the chest. And this is sometimes done for people who had other types of cancers, like Hodgkin's lymphoma, for example. They'll sometimes be treated with radiation that actually includes the breast area. And this significantly increases the risk of breast cancer. And that can happen even 15 or 20 years after the radiation. It's a very late side effect. Another thing is reproductive history, which really makes a difference. So the general theme is that any longer period of uninterrupted menstruation or ovulation tends to lead to a higher risk of breast cancer. So that means starting your periods earlier, having menopause later, or having your first child later. All of these things increase the risk of breast cancer. And then another thing that's important is increased breast density. So some women just have more dense breasts on their mammogram, and that can also increase the risk of breast cancer, partly because some early stage cancers can be hiding sometimes in those densities, and they can be harder to find. Now, something people often ask about risk is hormone replacement therapy, which a lot of postmenopausal women take because of menopausal symptoms like hot flashes. So usually it's combined estrogen and progesterone that women are taking. And we know that if you do that for more than 5 years, it definitely increases your risk of breast cancer. So the studies have told us, for example, that if 10,000 women take hormone replacement therapy for 1 year, then 8 additional women would get breast cancer in that year because of that group. So obviously for 1 year's time, it's not a big risk. It's an extra 8 in 10,000 women. But if you keep taking it for quite some time, that risk starts to go up, not just linearly, but exponentially. So meaning that when women are on hormone replacement therapy for 10 years, 12 years, that's when we start seeing a very high risk of breast cancer. So this is something to watch out for because it definitely changes a woman's breast and increases the risk of breast cancer. But the good news is that for women who stop hormone replacement therapy, their risk does come back to normal. So it's not a permanent increase in breast cancer risk. This is just a graph here showing women who've taken estrogen therapy. So interestingly, what we're seeing here is that the women who've taken estrogen therapy that's combined, estrogen and progesterone, have the highest risk of breast cancer. But women who've taken estrogen alone without progesterone, in many cases, it looks to be protective. So you can see here that women who are taking estrogen, which is the solid dark line, solid blue line, is actually, they have a lower risk of breast cancer than women who are taking placebo or not taking anything. So estrogen alone may actually be somewhat protective, but we can only use that, or women can only use that if they don't have a uterus in, because if you have a uterus in, taking estrogen alone significantly increases the risk of uterine cancer. So this is not something that we recommend for breast cancer risk reduction, but it's good to know that it's the combination of the two that tends to be the problem. So what are things that we can actually modify? And the good news is there are many of those things that we can actually change, unlike our family history or previous abnormal mammograms or having dense breasts. These 3 things are very important because we have control over these. So one is obesity. So we know that people who are very overweight definitely have a higher risk of breast cancer. And then also people who are sedentary and not exercising, or people who are drinking alcohol, all have an increased risk of breast cancer. So this is something that we need to definitely look out for and try to stay healthy and just make good decisions about exercising, eating well, and trying to keep our alcohol to a moderate level. This here is showing that for women, especially after menopause, who are able to actually lose weight, you can see that their risk of breast cancer actually starts to go down the more weight that they lose. And this is true even for people who start out at a lighter weight, they have lower risk of breast cancer. Now, in terms of diet, people ask me all the time, what type of foods should I eat or should I not eat? And what I always tell everybody is that there's no particular foods that are either really important to eat for breast cancer prevention or really bad to eat for breast cancer risk. But the general theme is that you want to be eating generally healthy foods. That means foods that have more lean proteins and fruits and vegetables, and stay away from processed foods and junk foods that we all know that we shouldn't be eating anyway. In general, for physical activity, the studies have shown that if you're getting 3 hours of exercise in a week, that only equates to about 30 minutes a day or so, we start to see a reduction in your risk of breast cancer. And the more that you're exercising, the less your risk of breast cancer is. And you can see here that these are people who are exercising, and all this is showing is that the people who are exercising the most, which is this line here, have the lowest risk of dying from breast cancer. So very important to stay active however you can, on average for about 3 hours a week. And I always tell folks it can be an exercise, it should be an exercise that you enjoy. If you don't like running, then don't run. You know, you can do whatever you like, whether it's biking, swimming, Zumba, you know, anything you want. But as long as you're active and your heart rate is getting up for at least about 3 hours a week, you're doing yourself so many favors. So alcohol is also another big one. This was kind of mentioned in the previous talk as well. So we know that when you're getting to more than 3 alcoholic drinks per week, this is where we start to see an increase in the risk of breast cancer. So you can drink, but having an average of about 3 or less per week is a good idea, because once you get above that, you're really increasing the risk of breast cancer. An interesting little fact is that for women who do drink, if they take folic acid, it seems to reduce the risk of breast cancer. So if you do partake more than you think you should, at least taking a folic acid vitamin supplement may be helpful for reducing the risk of breast cancer. And this is just a nice graph actually showing that the more alcohol you drink, the higher that risk of breast cancer becomes. So it's very much a direct relationship. Another thing that you can modify and that can reduce your risk of breast cancer is breastfeeding. Breastfeeding is so important. We all know that it's great for the baby, right? It helps improve their immune system, helps them grow healthy, gives them all the nutrients that they need. But also it's really great for the mom. It reduces the risk of breast cancer significantly. This is actually one of the reasons that we think that other countries tend to have lower risk of breast cancer, is that many other countries tend to do more breastfeeding than we do here in America. We know this is very healthy and really does help lower the risk of breast cancer. So in general, the basic summary here is that we want to be active, at least 3 hours a week of activity, maintaining a healthy body weight, meaning a body mass index less than 25. You want to be moderate in your alcohol consumption to 3 or less drinks per week. And if possible, breastfeed. And then also avoiding hormone replacement therapy is important as well, because we know that HRT does increase the risk of cancer. Now, screening. This is a really, really important part of what we can do to prevent ourselves from getting breast cancer, right? I always tell folks who come to see me that when they come with early stage breast cancers, very often they've saved their own life by getting a mammogram early when we could find something that's small, often precancerous, and entirely curable. So this is the whole goal of mammograms. So we recommend starting with a monthly self-breast exam when women are 20, and then starting to get a yearly mammogram at age 40, and then an MRI for certain patients who have a high lifetime risk of greater than 20%. For most people, the recommendation is going to be doing a self-breast exam, as well as getting a yearly mammogram once you turn 40. And then also, if you've had a family member who's been diagnosed with breast cancer, especially at a young age, then we do recommend that you start 10 years before that person's diagnosis, even if that's before 40 years. So for example, if your mom was diagnosed with breast cancer at 45, then we would recommend that you start getting your mammograms at 35. So breast exams, these are really important. Now they can be done by your gynecologist or your primary care doctor, but you should also be doing it once a month. The best time to do it, if you're premenopausal, is about a week after the period starts, because a week after your period starts is when you have the least lumps and bumps in the breast, and it's going to be the least confusing for you to do. And you're looking for changes in the skin that could be like dimpling or redness or puckering. You're looking for changes of the nipple, like nipple inversion. And then also obviously feeling for any masses under the arm or in the breast. These are all really, really important. And if you see any of these are extremely critical that you let your doctor know right away. Now, typically breast cancer doesn't have any symptoms, meaning it's very rare to have pain or any other sensations with breast cancer. So it's very important that you do your exam. And if you find anything abnormal, make sure that you're getting a mammogram and ultrasound. So mammograms, the reason why they're so wonderful is that we can find things often before they could even be felt. Literally, we can see little dots of calcium that are in the milk duct on these mammograms. And this is something that's so tiny that nobody would feel it, but if we find it at that stage, the cure rate is typically 100%. So we can find the earliest cancers using these mammograms and ultrasounds. So one of the reasons why some people are scared to get mammograms is about radiation, right? Because we know that it does expose us to some radiation. So just to give you guys an idea, I know this is very busy, but the whole point of this is to let you all know that this is representing how much radiation a mammogram has here. You can see that it's about 400 microgray. So very, very little radiation. Now, if you look at how much radiation we would typically get, let's say from a CAT scan of the head, that's a lot more. It's about 4 times more radiation than we would get there. And if you look at what we're getting with a CAT scan of the chest here, that's a lot more radiation than we're getting from a mammogram, right? So in general, this is a very, very small amount of radiation. Doing it once a year has been proven to not have risks associated with extra cancer, quite the opposite. The mortality from cancer is significantly reduced because we're finding cancer so early for a very low cost in terms of the radiation. The other nice thing is that the new radiation or the new mammography techniques that we're using now actually use less radiation even than this. This is actually an older slide talking about the older technology, and the newer ones use even less radiation. So this should not be a concern. Now, as I was saying, we know that it reduces mortality for all women, and especially for those women who are greater than 50 years old. There's about a 22% reduction in mortality. There are not many things in medicine that we can say do that, but mammograms do. This is a very big deal. This is something that we should all be taking advantage of. Now, in general, like I said, we know that risk of breast cancer goes up as you become older. So women who are in their 40s definitely benefit from mammograms, and they should get mammograms, but their risk is much lower than somebody who, for example, is in their 60s, where their risk is 1 in 27 versus 1 in 69. So this is part of the reason why there's been a little bit of controversy about when people should start mammograms. Recently, the US Preventative Services Task Force came out with some recommendations, which I'm not going to get into too much in this talk, but basically they were saying that we need to get mammograms more frequently in people who are older because their risk of cancer is higher and we're more likely to find cancer for them. While this is true, it doesn't mean that mammograms don't have a use for women who are in their 40s. It definitely does. I see women every day in my office who are in their 40s and sometimes even in their 30s who have breast cancer. So absolutely getting those mammograms is extremely important. And you can see that here. This is talking about the number of breast cancer cases that we see. And you can see that it really starts to go up for women in their 40s and then really just continues to increase beyond there for women into their 60s. But there's really quite a few breast cancer cases in this age group. And this is actually breast cancer deaths. And so you can see that, again, women who are in their 40s are definitely dying of breast cancer at rates higher than we would like to see. And this also shows us that for years lost, meaning for a young woman who's diagnosed with breast cancer, especially if it's at a later stage because she was not getting her mammograms, the number of years of life lost is obviously much greater for somebody who's younger versus somebody who's older. So this is something we also take into account. So the American Cancer Society still does recommend annual screening, definitely for women who are ages 45 to 54. And then for women who are 40 to 44, it's more of a discussion to have with your doctor. Not everybody necessarily needs to start screening at that age, but for many women, we would say to at least start getting baseline mammograms at age 40. And then depending on what it looks like and what your family history is, you can decide whether to get it every year or start again at 45. So because I know we want to get to that walk at the end, the tiger walk, I'm going to skip some of these. But what I will show you is this. In general, my recommendations for who should be getting mammograms, which is kind of the bottom line of all of this, it's very important to evaluate your risk. And the things that you can know that would give you, that would let you know whether you're in a high risk or not, are all the factors that we just talked about. So for example, if you know that you're somebody who has a strong family history of breast cancer, you should definitely be starting your mammograms at 40 and getting them every year. If you've had previous abnormal mammograms and had to have breast biopsies, that's another reason to definitely be getting your mammograms every year. These are all good things to discuss with your doctor, and there's actually calculators that your doctor can use. There are certain factors they can put in to a certain risk calculator to decide how aggressive we should be in terms of getting mammograms, perhaps getting MRIs, maybe even starting medications to reduce your risk of breast cancer. So these are all good conversations to have with your doctor. And And this is also just to show us a little bit about what a 3D mammogram is. You guys have probably heard about these 3D mammograms, right? And most major centers in town are now doing these because these have proven to be better. So when we get a 3D mammogram versus a 2D mammogram, we're more likely to find cancer if it's there, and we're less likely to call ladies back for additional imaging or biopsies for things that turn out to be nothing. So they're basically more accurate. When they tell us that there's something there, it's more likely to be truly something that we would want to know about. So this is just an example to show that for a 2D mammogram, let's say you have some overlapping areas like this. If you're just kind of squishing the breast, you can't really see it very well because things can hide behind other areas. However, when you're getting a 3D mammogram, you're kind of taking serial sections. You're doing slices all along. So the example that I give often is that it's like if you're trying to find one single raisin in a whole loaf of cinnamon raisin bread, right? If you're just looking from the outside, you're probably not going to see all the raisins that are on the inside in the center here. But if you're taking cuts like this, slices all along there, then you can start to see inside what's actually there, right? So this is what a 3D mammogram does. It takes several slices along the way. And this is generally considered to be the standard. Some insurances will charge a little bit more for a 3D mammogram. But when possible, you should talk to your doctor about this and try to do a 3D when you can, because it is more accurate. Now, I'm just going to say a few words in terms of treatment, only because I think that a lot of times people are scared to get a mammogram because they're worried about what's going to happen next, right? So if it does show something, people are very worried sometimes about what the treatment would require for cancer. But actually, it's not that scary, and hopefully we can demystify it a little bit today. So there are so many different types of breast cancer. You hear these words like triple negative and HER2 positive, and the only thing that means is that it's telling you the behavior of that cancer. So they all behave a little bit differently, and they're all treated very differently. And some of them don't even require chemotherapy. Many of them are not very dangerous, actually. And then others are much more serious and definitely do require chemotherapy. So in general, a big part of what we look at is the stage of breast cancer. And the stage is determined by the tumor size, whether there are lymph nodes involved, and whether they're spread to other places in the body. And based on the stage, the treatments may be different. So early stage cancers often have simpler treatments with much less toxicity, much less side effects. And this is why we want people to get their mammograms, so we can find the cancer when it's small and early stage, and we can cure you very easily with very little treatment. So surgery is something important to talk about. Sometimes people choose mastectomies where we have to remove the entire breast, but more commonly we do lumpectomies, which is a small day surgery. You come in the morning, you go home in the evening, and the recovery is literally about 1 or 2 days, and people are feeling really good afterwards. So it's a very simple surgery. And many people also get radiation. Radiation is a simple procedure that goes on every day for about 4 weeks. And it's like getting a CAT scan. You lay on a table, you go through a machine, and you can have some side effects to the skin, but it's fairly straightforward and not too difficult for most people. So either option is fine, whether a mastectomy or a lumpectomy with radiation. The outcomes are actually the same. People actually do just as well. A lot of women think, oh, if I have cancer, I must have to remove my entire breast. But that's actually not the case. People who get the lumpectomy and radiation do just as well as the folks who get the mastectomy. These are some of the pros and cons of both lumpectomy and mastectomy. And we'll usually go through this with cancer patients, and each patient has their own goals and their own reasons for choosing it. But the important thing is to just make an informed decision, just so you have to know what is involved in each option, and then you can choose which one is best for you based on your situation. This is just an example of what happens at the time of the surgery. They will remove some lymph nodes because they want to make sure that the cancer has not moved the lymph nodes. So they inject a special dye into the cancer. And then the first couple of lymph nodes that it goes to are those sentinel or gatekeeper nodes. So those are the ones that are removed, and we're looking for cancer in those nodes. And then some people will require chemotherapy. It can be given either before or after the surgery. And we do it often because we're trying to shrink the cancer down before the surgery, or we're trying to kill any little microscopic cancer cells that are trying to move to other parts of the body. We want to obviously make sure that we kill them before they can really set up a location in the liver or the bones or anywhere else. So there are many side effects of chemotherapy. It is tolerable, it is doable. But again, this is one of the main reasons that we love when people get early mammograms. Because when you're getting mammograms, it's actually much less likely that you'll need chemotherapy, because oftentimes we're finding the cancer so early that the cure rates are excellent without even having to go through chemo. And then radiation I spoke about a little bit. Like we said, it's usually an everyday procedure, kind of similar to getting a CAT scan. Very doable. And then just a few words about hormonal therapy. You know, we have two different types of hormonal therapy that we use. And the main goal is to lower estrogen in the body. So we do see side effects that are similar to menopause. Things like hot flashes, vaginal dryness, joint pains, hair thinning. These are all very common side effects that can happen. Okay, so a quiz, pop quiz, to see who was paying attention. So, which of the following is not a proven way to minimize your risk of breast cancer? So it's saying which one is not a way to reduce the risk of breast cancer: avoiding alcohol, losing weight, a breast self-exam, or exercising regularly. Yeah, so this is kind of a hard one, but you guys got it, I heard it. So C is the right answer, right? Because the breast self-exam, we recommend that you do it because if you find something, you definitely want to show it to your doctor. So it's definitely important. But in terms of minimizing your risk, it doesn't do that. It just helps you find something sooner so that you can go to the doctor, right? But there's nothing but a breast exam that's going to reduce the risk. But all of these things, avoiding alcohol, losing weight, and exercising regularly, they actually reduce your risk of getting breast cancer in the future. Okay, and then which of the following are especially concerning if found on the breast self-exam? And there could be more than one answer here. There is more than one answer here. So it is pretty much all of the above, except pain. I would say I wouldn't ignore pain, but pain is not typically a sign of breast cancer, but everything else on there can be. Redness, absolutely. Dimpling, a lump, new nipple inversion, all of those are red flags. And if anyone ever sees that, it's really, really important to talk to your doctor right away. If you don't have a doctor or if you don't have insurance, there are many other options too. Dr. Ajawole was talking about one of the grants that we're lucky enough to have through CPRIT, where we're funding mammograms for women who may not have insurance or can't afford it. But even if you don't know about a place like that, you can always call up a place like The Rose. The Rose is wonderful. They offer mammograms to many women who are uninsured or underinsured at low cost or no cost. There's always an option. I always tell people, don't just think that you can't do anything. Just talk to somebody, ask, and you'll find a way. All right. So that is everything for my talk. Do you guys have any questions about anything that we talked about? Yes. Okay, great. So the question was, if you're postmenopausal, when is the best time to do a self breast exam? Which is great. We talked about if you're still having your periods, then you want to do it a week after the period starts. So if you're postmenopausal, because you don't have that hormonal cycle anymore of estrogen and progesterone going up and down all the time, it means that you can do it really anytime you want. There's no change. There's not likely to be any change in your breast, at one time versus another. So I always tell people, just choose a day of the month, like the first day of the month or the last day of the month or whatever's easy for you to remember. And you just want to do it regularly every month. Make it a habit. Either in the shower is a great place, or when you're laying down in bed, that's okay. It's a great place to do it too. But you want to make sure that you don't forget. Yes. Mm-hmm. Yes, definitely. So the question was about family history. So if you have a family member who's, let's say, a half sibling, where you share one parent but not both parents, should we be doing genetic testing still? And the answer is absolutely yes. Especially more so, let's say if you know that that parent that you both have in common, if there is a family history of cancer on that parent's side. So maybe that same parent has their own mother with breast cancer, or somebody else with ovarian cancer in the family, a cousin or a sister, then definitely you should get genetic testing also. And the reasons to really consider genetic testing more is especially if you have people in the family who are young and diagnosed with cancer. So young being like especially people who are in their 40s or below, then that's a really good reason. There's a higher chance of having a mutation in that case. Okay, great. Thank you everyone for your time and attention.